So our next session is a chance to think about and discuss different ways of approaching chronic disease management. So we have three 10-minute presentations, and then we're going to ask the three presenters to be up the front and have a general discussion and questions. So first, pleased to introduce Susan Ryan, whose work has spanned across different health and education sectors, advocating and empowering vulnerable rural communities. And she's talking to us as the manager of Camperdown and Lismore Community Health as part of South West Healthcare.
Okay, I thought I might just start by giving a bit of an overview of our community, so you get an understanding of how we've built our model. So Camperdown Community Health, 2 hours from Melbourne on the Princess Highway, got the iconic clock tower and the main street. It's a farming community, beef, sheep and cropping. Camperdown is the capital of the Corangamite Shire. Okay, so who lives here? We've got a very small population, so 3,000 people. Mainly 50% of these residents are over the age of 50, with a further 32% being over the age of 65. So as you can imagine, this puts a growing demand on our health and leisure services. This is predominantly due to young people leaving for employment or further education. We have a really high rate of volunteering, which is around 50% compared to 19% of the state, which has been something that we've really worked on to strengthen our program. So community engagement has been a big part of what we've built our program on. It's a reasonably vulnerable community, with 30% of our households earning less than $650 a week. Okay, our key health concerns, we have a high rate of registered mental health clients, high rates of heart disease, high rates of obesity, low rates of physical activity and low rates of fruit and veggie intake. So not surprising, pretty much a national standard there. So our service is a very small rural community health service. We're one of 4 campuses of South West Healthcare, the others being in Warrnambool, Macarthur and Lismore. We have a broad range of allied health services, social support, health promotion and community health. We have 3 main funding streams, which is the state government community health program and home and community care, and the federally funded Commonwealth Home Support Program. Okay. So in 2017, we were fortunate enough to receive funding from PHN to develop a chronic care model. Now, I refer to it as a chronic care model here, but to our consumers, we referred it to as a wellness model, because probably you're all aware, you say to someone, how's your chronic illness? And they go, what chronic illness? So it's really been about empowering people to change their behaviour and improve their health. So under this particular funding stream, you had priority areas, and based on the data that I've presented, we looked at diabetes, type 2, cardiovascular disease, and a very small component of ours is musculoskeletal conditions. So our service has, as you can see, dramatically increased over that period of time. It's at approximately a 12.5% increase with client contacts, with the bottom figure being only over the last 6 months. So we're again looking at that same 12.5% increase for this financial year, which is also attributed to our growing workforce. Obviously, 23 doesn't represent full EFT, so across different portions. Okay, the key features of our model is a holistic needs assessment and a collaborative care plan, supporting healthier lifestyles by empowering clients to develop achievable goals, providing clients with the skills and education to manage their condition, and allowing clinicians to work in the most appropriate, efficient way, helping clients to navigate the healthcare system, and it's really about a focus on ability instead of inability. So our team consists of dietetics, intake and assessment. Now, intake and assessment actually has 2 prongs to it. There's a clinical component, which is a nurse, who's necessary for more complex referrals, but we do tend to use non-clinical staff for a lot of our intake. As I spoke about before about workload efficiency, we've got our staff working where they're meant to be working and not wasting time putting in all the stats and non-clinical tasks. Exercise physiology, physiotherapy, diabetes educator, podiatry and social work. So with a team that large, you can imagine communication is a priority for this program. We are fortunately co-located, which does make things easier. We've developed a universal holistic needs assessment and a universal goal setting tool. Now this is all located on a shared electronic medical record. And then we've introduced diabetes huddles, joint consultations, so someone might come in and see the diabetes educator and the dietitian in the one consult. And then we have bi-monthly multidisciplinary team meetings where we discuss clients that are high risk. So it's about giving the right care at the right time by the right provider. We take referrals from GPs, specialist physicians, other health professions and self-referral. We're finding with this program as it grows momentum, the majority of our referrals are coming from the clients themselves. We're working in with the GPs and hosting early morning breakfasts, because that's generally when we can only get a GP, and building our relationship, because as I said, we're not co-located. So how we work, as I said, we've got an intake model. We take baseline measurements and we establish client goals. And from that intake session, we will then decide what is the most appropriate clinician to work with this particular client. And then we offer our wellness programs, which I'll talk about on the next slide. They receive Go Share resources, which I'll refer to later. And then this is reviewed every 6 months. So our wellness programs is something we've just introduced over the last 4 months. In community health, we're very target driven so that we can continue with our funding. So we've got to a point where we're meeting our target and we're really focusing on the quality of our program and the outcomes for our clients. So even though we were working as a multidisciplinary team, we felt that our clients still required some motivation and education to embark on new behavioural practices. So we've introduced an exercise program, which is in a tiered process, where the client will see and receive a personal exercise program, and then they move into a very basic group called Healthier Me, which consists of 45 minutes of exercise and half an hour of rotating education. So 1 week they might see the diabetes educator, the next week they might do a shopping tour with the dietitian, the next week the podiatrist might come in and do a talk as well. So it doesn't matter when you join the program, because it's a rotating schedule. So once we feel that they can move on from Healthier Me, they go on to a Live Longer, Live Stronger program, and then a cardiac fitness. And we're currently negotiating with the local gym, because we're already at capacity. Our health service could probably fit in half of this room. It's tiny, and it's not a purpose-built health service. It was once a shop. So when I'm talking about these exercise programs, it's not a flash gym. It's an exercise bike and a treadmill and some free weights and a lot of motivation. And we feel that the clients exercising together and that social support has been a real success of their outcomes. So as I said, once they reach level 4, they'll actually have to move into the local gym, because we've got too many referrals coming through and we can't cater for everyone. Oh. So I'll just play a little video on the Go Share. Might need some technical, yep. Won't work? Okay. So Go Share is actually part of what the PHN, a resource they provide, services that are funded under their guidelines. So clients receive electronically information post-appointment. So for example, they may have seen intake Monday. We schedule that by Friday they will receive either on their iPhone or via their iPad or computer a motivational video around someone else that might be newly diagnosed with type 2 diabetes. It might be more reading material. There's a whole suite of resources attached to Go Share. You don't have to make them up. You basically go into the library and choose what would be relevant for your clients. So it's a really good resource to have. So our outcome measures, which is a really different way of thinking in community health, as I said, we're really target focused. So this is the first funding that's really made us accountable for client outcomes. So we collect data every 6 months that's sent off to the PHN, and we also look at whether the client's goals set have been met. And there's also a service delivery survey that is filled out in conjunction with the baseline measurements. So I just put 3 very basic case studies on here. The first one is actually a gentleman we would say is not very engaged in our program. A type 2 diabetic has been diagnosed for some years. He's got very poor diet and is very reluctant to change that diet despite our clinicians trying to motivate change there. He has had some improvements, obviously with his blood pressure and his weight. But for me, I chose this client because he's well connected to our service, even though he doesn't perhaps change his behaviour like we would have hoped. He's joined our social support group and he's just newly been diagnosed with cancer. So even though for us he's not meeting our outcomes that we would like, he's actually been on a different journey and his mental health and connection to the community has actually really improved. So that's not something we're currently measuring, but for this particular client and his recent diagnosis, that's been very important. Our second gentleman is a newly diagnosed type 2 diabetic. He can't exercise due to mobility issues, so it's really been around dietary intervention. He's had a 9 kilo weight loss, which has obviously affected his BMI, but more importantly, he's been able to reduce his insulin 3 times a day to oral meds once daily through modification of his diet only. The third case has got excellent engagement. This gentleman is newly diagnosed type 2 diabetic. He had a very poor diet and didn't exercise at all. He's had significant changes in his weight and BMI and HbA1c. But for us, it's really around this gentleman's blood pressure has gone from 170/80 to 118/70 with no BP medication intervention. So the challenges for us in community health are juggling multiple funding streams and associated targets, engaging clients that want to make a change, keeping clinicians on the same page and working collaboratively, and changing the mindset from funding targets to a focus on client outcomes. Thank you. I think we're going to have a panel at the end. So.
Thanks, Sue. I'd like to ask Dr. John Barrell to come up second, please. John's a rural procedural GP at Springs Medical in Dalesford and Trentham, and he's going to discuss with us their Put a Spring in Your Step program. Thanks, John.
Thank you. I wasn't quite aware of what Susan was going to be talking about, so there's a little bit of duplication. I'll skip past that. The thing that I want to persuade people of is that you can actually do this in private general practice. This is our Spring in Your Step program, and I would say to you that it's exciting, it's fun, it's very different for general practice to my knowledge, it's been very good for our brand, it's actually good for our bottom line, and the patients love it. There's a couple of patient photos here, they've consented to that, and I think like our keynote speaker this morning, if you keep using the same systems, then you keep getting the same results. And so if you want to get different results, then you've got to use some different systems. There's a few brochures on the back tables, I think, but it's also all on our webpage as well. I think we all remember how it used to be. We did our work behind closed doors. Patients only got to cardiopulmonary rehab if they had an event or if they were near end stage. And then after rehab, if they could get there, if they could afford it, then they were out in their ear, there was no follow-up, there was no ongoing support. So with the... oops, too far. That's right, there we are. So with the 2017 grant program, we had an idea. Again, we call it a wellness program, but the key difference is that I think it's delivered locally, it's delivered by locals, it's delivered for locals. We decided to give it a sexy name, and we partnered with Creswick and Clunes Medical Centre so we could deliver the program across all of Hepburn Shire. And we had an additional goal, which I think is really important, especially in rural areas, was to build infrastructure and sustainability, both in our rural facilities and in our allied health practitioners. You know, it's really hard to get allied health people to come to the country, and if we can develop an enterprise that makes their enterprise more sustainable, then that's a good idea too. There's some conditions to the grant. The clients, patients, pay between $9 and $18 per week. That's means tested, but nobody is to be excluded due to inability to pay. And we are required to draw upon the Wagner chronic care model. Mr. Squiggle, or whatever his name is, was a medical researcher in Seattle, and that's the model. It's about being multidisciplinary, it's about using IT, it's focusing on quality, it's giving education to patients, it's empowering patients, it's self-management, it's measuring anything that moves, and it's pursuing continuous improvement. So we had to recruit some people, and so we recruited a coordinator, that's Karina on the left, and we recruited an exercise physiologist, that's Brie on the right. Karina, the coordinator, she's a registered nurse. She's run a heart failure project at the Alfred, so she could walk the talk, so to speak, in terms of interfacing with bureaucracy and how these sorts of grants need to be run. And initially we were restricted just to cardiovascular and pulmonary disease, but in the second and third years we've been able to expand into diabetes, mental health, which has been really important with the ability to include that. We run a youth wellness clinic at the local secondary college. We've been doing it for years, long before the state government thought of a doctor in schools program, and that's been fantastic to engage young people to come along to this as well. And of course musculoskeletal conditions, because if we can improve people's mobility, then plainly it's also going to help them with those first two, cardiopulmonary. The aims of the program are pretty obvious. This is Roger. And when I first met Roger, he was on portable oxygen, he was much more obese, and he was on the wait list for a lung transplant. And 12 months later, he's off oxygen, he's less obese, he's not in hospital, he's motivated, and he's helping and encouraging others to join the program. I mentioned measuring everything that moves, and so the learnings from the first year was to include those additional risk factors that impact upon mobility. But the biggest benefit, overwhelmingly, has been the psychosocial benefit. So that wasn't our initial goal, but the feedback that you get from the clients is, I feel part of something, I belong to a group, I was isolated and now I've got somewhere to go. And that's been an enormous help for people in the community who felt isolated or neglected. So the first year we ran a 12-week program, a more traditional sort of cardiopulmonary rehab program, 6 weeks and 6 weeks, and we had a fair bit of drop-off into the second 6 weeks. And so the learnings from that was to, in the second and third years, to move to a more intensive or comprehensive 8-week program, again, education plus exercise, followed by a step-down second 6 weeks of supported exercise, and then hopefully a seamless transition into an ongoing self-managed program. I'd mentioned sustainability and upgrades to local facilities. So not only are we using local allied health practitioners, and it's interesting, here we are, a private general practice of 4 owners, about 15 doctors and a variety of allied health in the practice. Despite being one of the 2 directors responsible for managing this grant program, which is about $230,000 a year, I've actually never set foot in a springing step session. I mentioned our coordinators we've appointed. Yes, we've got a management committee that organises it. This has been relatively easy to run as an add-on program for our enterprise. And through that, we've developed upgrades to the Trentham Football Netball Club with equipment. We've put in some defibrillators. We've encouraged upgrades at the local gym, which went from a very minimal hours operation, and it's now much more extended hours with remote key access. So it's fabulous to be able to underwrite the careers of allied health practitioners and also to improve local facilities. Part of walking the talk is understanding the key enablers. And the thing that I think has really worked for us is recommendation by your local doctor. So when I say to someone, I think you should join our Spring in Your Step program, I reckon I get 8 out of 10 saying, yes, please. The word of mouth, again, in a community, they see people going, they hear, they see the benefits, and so when someone says to their friend, this program's fabulous, other people listen. The waiver, the fact that no one's excluded due to inability to pay. I was nervous that people would perceive some inequality in the system. Why is this person paying $18 a week? Why is this one paying $9 a week? Why is so-and-so paying nothing? We haven't had one complaint about that. And the fact that I can write a referral, which we do electronically, of course, through our software, and note on that, fee waiver if appropriate, and people who would otherwise not have access are able to. This fella, John, had near end-stage chronic airways disease, and his goal was to be able to get to Terminal 4 at Tullamarine and be able to catch the plane without having to use a golf cart to get to the end of the terminal to go and see his grandchildren in Townsville. And recently I was doing a parallel consulting session with our Deakin University students, and I asked John about the Spring in Your Step program, and he said, look, it means everything to me. He said, Thursday's bocce now, and the bocce day in the Trentham Town Square, so your appointments for me to come and see you have to fit around when I play bocce. It's been transforming for many folk. And the final little story tale is Mason. Mason had Parkinson's disease, couldn't work any longer, enjoyment of life was deteriorating, and he enrolled in the program. And now he's self-managed, he goes to the gym himself 6 days a week, and again he spruiks the program to all. So the opportunity, I think, what next? Again, thinking of our keynote speaker before in the earlier session, we need to develop a model that's sustainable without government subsidy. We need to persuade government that preventative health programs are money well spent. We need to spread the word that private general practice can be a very effective way of managing chronic disease and can do it very efficiently and effectively. And most excitingly, I think from the patient's point of view, our patients now see Springs Medical as being much more than a place just to go to when they're sick. They're very happy about it, and I think it's put a spring in their step, and hopefully it has in yours and mine. Thank you. Oh, and I was going to show you, we do promote ourselves shamelessly, so we have little bags and so forth that people get, and they get the Spring in Your Step drink bottle, and they get little Spring in Your Step diet plans and fridge magnets and so forth. So, using all the modern tools of promotion, if you go onto our webpage, you'll see a little video that we've made with nice little Wombat Hill in the background and my round head. So there we go. Thank you.
Thanks, John. So I'd like to now introduce our third speaker for this session, who's Dr. Tim Denton, who's a GP in Geelong, and he's going to talk to us about what they've been able to achieve at Cardinia Health in multidisciplinary chronic disease management.
The last two speakers have just proven my point. Diet and exercise is what it's all about, and we really need to engage in that. And taking blood pressures and feeling pulses and rates is the next most important thing. So I'm going to talk about the perspective from the provincial city point of view, as opposed to sort of rural point of view. So it's slightly different, but the themes are very similar. And this is a systemic sort of approach to systems. So chronic disease management at Cardinia Health is what we're talking about. Whoa. So basically the way we manage it is working within a multidisciplinary team, and I think that's sort of coming through in this sort of discussion today. So care planning is delegated to nurses simply because they're good managers and they have the time to listen. And if we don't recognise the difference between the nursing profession and the medical profession in that little statement, then we've got a problem. The GP is the ultimate arbiter and, of course, responsible to the coroner, ultimately. So that has to be factored in as well. The care planning concept is a consensus document between the GP and the patient and the team. And this is really important because this is the sort of patient-centred approach that we really need to be sort of moving towards. Allied health clinicians have an incredibly valuable part to play and therefore needs to be looked at. For more complex patients, those that are sort of not quite getting the outcomes we would expect, we've moved into a process of delivering health coaching. But friendly staff make the patient feel confident, and it really does make a difference. The ambience of the clinic, the lack of grumpiness of all involved does make a big difference. So why care planning? Basically, the evidence and E.H. Wagner's work is seminal, and he was a physician, an American physician, as was stated. His principal premise was the fact that we're not getting the outcomes despite the input, and he was looking at a whole systemic approach from the US point of view. His point was, when he sat down and looked at it, was, hold on, we've got to get the patient into the team, and we've got to start working with what patient priorities are about. So it really shifts the balance away from the old-fashioned outpatient clinic where the patient gets processed and sort of spat out at the end. Sorry. So we're looking at improved patient outcomes for patients with chronic diseases. We're looking at a reduction in preventable hospital admissions, and the federal and state government really want that one. We want regular reviews. It's really interesting when you do care planning, looking at what the work that CDMNet did was they found that the original care plan set up that you get your money for was brilliantly adopted. Only 20% were reviewed within 12 months. Now, it's the money is in the review, not the original care plan. So it's interesting. So regular review, constant monitoring of the patient, and being proactive is really what it's about. And setting up a team, particularly with nurses chasing, is really important. Patient satisfaction, attention to health literacy, and it's a really important point, just having the ability to sort of make sure the patient understands what you're talking about, even getting the patient to actually report, talk back to you about what you just said is important. And participating in care, the patient participating in the care, they're actually part of the team. It all helps motivation. The best way to create a GP management plan, we can go into great detail here, but basically consent, discussion and agreement, a collaboration with the patient, looking at the healthcare needs, the health problems and conditions that need to be managed, and management goals in which the patient agrees. So there's a lot of focus on the patient agreeing in this, and it's really important. And finally, to do the patient, you finalise the plan, you give a copy to the patient if they want it, and you're off to the billing, which is important because we've got to actually try and make this work. Enablers, look, we can get carried away with all these slides, but basically there's a lot of different factors there. Working within an integrated primary health system is great. We have a pharmacy that sees 80% of all our patients. 80% of all prescriptions that are prescribed at Cardinia Health are actually dispensed in our pharmacy, which means that we can have enormous feedback, and I'm constantly liaising with the pharmacists to get feedback. We've made some enormous roads into narcotic prescribing in the last 12 months at Cardinia, and a substantial change in the behaviour patterns, principally with collaboration with the pharmacy. And they'll give you enormous feedback that you mightn't expect. Primary prevention, the RACGP found basically that screening patients, 25% were at the recommended blood pressure target. 75% aren't. So we need to be factoring in some of these things. 50% had good blood pressure control, blood sugar control, 50% didn't. And 20% only had their cholesterol treated well. So they're just, something's happening here. We're falling through the gap. When we look at what data the Grattan Institute offered, basically looking at some of the things to look for, smoking cessation, the notes. They looked at the notes, and only 0.6% of the notes, the electronic medical record notes, showed any evidence of discussion of smoking cessation. Doesn't mean it didn't happen, but it wasn't documented. Likewise, discussion of nutrition, 3.4%, they found evidence of discussion of nutrition. 0.3% discussion of alcohol, physical activity. Now, this is obviously happening. It's just not being documented. And if we want data, because research, Grattan's a pretty good institute for research, they need to understand how to improve health outcomes. So what's coaching about? We're looking at patient engagement is crucial. The coach, we're looking at those patients that simply haven't quite engaged properly. The outcomes are looking pretty well flatlined or getting worse. And the aim is to actually send in a mentor, a well-trained mentor. In our case, we have 2 nurses that are doing it, and they've been trained in the process run by the USA called Well Coaches USA, which we got out to Geelong in December of 2017. Basically, the theme is that what's concerning you. So what's the patient concerned about in your health and well-being? If you want to engage and actually get traction, you actually have to work with what the patient's focusing on, not necessarily what you would see. That might flow later. What do you feel you're doing well? So you start to look at what the positive aspects of what the patient's doing, because out of positivity comes confidence, because we're in an empowering of the patient's situation here. We're trying to empower the patient to take more responsibility for their condition. Almost all of these people that ended up with coaches had hidden mental health problems. They're just not being turned up until we got into the coaching process. So it gives you an idea how that's had an impact on the way their motivation's been delayed. And then you start to work on sort of looking at where you'd like to work with, what sort of assistance you'd like, and so on and so forth. So the SNAP is what's your smoking behaviour, what's your nutrition behaviour, what's your alcohol intake like, and basically physical activity. If you capture that into a simple little SNAP anagram, you can actually start the process of just quickly asking these questions. Because once you're sort of aware of it and make the patient aware of it, it starts to become more mainstreamed. Twice as many people die of opioid overdose as road toll in Australia currently, and the figure in the US is just out of control. So we've got an opioid problem here. So we start talking about some of the stuff that we've done there, and essentially at Cardinia, we've worked with allied health conditions, clinicians, nurses and GPs to work together to try and have an impact on reducing opioid use. So my point would be that we have a tendency to underuse allied health clinicians. With chronic pain, we tend to sort of have a tendency to go to narcotics rather than looking at the multidisciplinary team we've got there, podiatry, physiotherapy, dietetics, etc. And if we use them as the first step rather than moving straight up to endone, etc., we might actually try and control the opioid problem that we've got. Pharmacists, as I say, become a really valuable member of this team. So I'm constantly plugging the concept of team-based process. We can simplify the drug regime. Sometimes they're incredibly complex. And it's because they've seen lots of different doctors and it's all been tacked on, and all of a sudden you've got to clear it all out and start again, or at least rationalise the drugs. So just as an example of how we were able to affect this, these are year-on-year figures. So when we look at the year 2016, we had 85 patients on MS Contin. These are the Cardinia Health Pharmacy figures. At that same year, we had 584 on oxycodone, whether immediate release or extended release, diazepam 128, and temazepam 77. So that were the number of patients being prescribed these drugs. By 2017, the MS Contin had dropped to 68%. So it's a 20% drop, but in fact, they'd moved over to the oxycodone group, most likely, which had grown by almost 8%. The benzos were pretty well staying much the same, and the temazepam had increased. But by 2018, after a fair bit of work was put in, MS Contin was fading into the sunset. But the reality is that the oxycodone growth has actually slowed right down. So when you combine the MS Contin and the oxycodone, we'd actually sort of started to turn it around. The 2019 figures will be really quite fascinating. Likewise, in the diazepam area, we've actually had a 9% decrease on the 2018 figures compared to 2017, and we're still below 2016. So there was progress made there, and likewise a small drop in the temazepam figures. But the point is, by collaborating with the pharmacists and working with the nurses too, we've been able to actually make an impact on this. The figures for the next 3 years are going to be really interesting to watch. Clinical governance, I'll be very quick because I'm probably running out of time, but basically you need clear lines of accountability and responsibility within the practice. Everyone needs to understand their scope of practice and work towards it, but ultimately the GPs are accountable to the coroner. We need to be assured that we're providing safe and quality clinical care, that we have leaders who take responsibility for this safety and quality care. These are the RACGB guidelines, by the way. And we need to share information of quality improvement and patient safety within the team. We need to work as a functional team. And so we need to look at ongoing education within the team, clinical effectiveness. We need to look at the evidence of that. We need to generate it. And risk management is always an issue, both clinical and financial risk. Clinical audits have been quite useful at Cardinia, and we've done a whole pile of them, not only the narcotic one. And then we've got the capacity to actually lead into research and development, which we've got a research capacity at Cardinia. Transparency is the middle line. So that does me. But it's essentially a system shift, and it's patient-centeredness. So, and respect within the team. I think that's really important, the mutual respect within, right across the team, and delegation across the team to the appropriate people in that team is what we're on about. But I think we've got a panel.
Thanks, Tim. So now we've got a bit of time for questions, either general or specific, about the things that these guys have talked about, and a bit of discussion about the different approaches that have been undertaken in these 3 different settings. And we have got a microphone if people want to stick their hand up.
I'll ask Tim a question, if I may, while we're getting organised. How do you deal, Tim, in an urban environment where there are multiple practices, in going to all that effort and then discovering that your 721's been billed by the practice down the road?
A simple answer to that. Until they bring in healthcare homes and stop that with capitation, that big nasty C word, we're not going to see that ended up. And I experienced that in Colac. Colac is one example of a place where that is, they are stripping those item numbers out, so the GPs and the 2 main clinics don't get in and get their fare running. It's a really big problem. Until we have capitation, we won't get around that problem.
I was wondering, in the Camperdown group, how's the engagement with the GPs in the town? You mentioned that there's multidisciplinary meetings, but does that include with the GPs apart from just meetings you're talking about?
No, unfortunately it doesn't at this point in time, but we're currently negotiating that, and one of the initiatives we'll look at is co-locating one of our staff members in one of the GP clinics, which is what Barrell Community Health do. So it's very hard to get GPs away. Your time is precious, and I understand the time you're away costs money. So it's about us being able to negotiate a way that works best for you with the client at the centre of our focus. Yep.
John, this is a question for you. Just wondering if you had any investment from the Shire or any of the local services. You mentioned the big infrastructure changes, so was there local investment as well?
In spirit, but not in kind. It was interesting when the grant became available. We learned during and after the fact that we were in competition with the local health service. Hepburn Shire is a curious place. It's that horizontal thing that runs from Creswick on the one side across through Clunes, Dalesford and through to Trentham. And the footprint of Hepburn Health Service pretty much matches the footprint of Hepburn Shire, which pretty much matches the footprint of Springs Medical across Dalesford and Trentham, and Creswick and Clunes Medical Centre, that's obvious. And so we learned that in applying for this grant that our opposition was Hepburn Health Service applying for some funding for a psychology program, possibly to replace the monies that the state government had taken out of their monies to continue the psychology program. For better or for worse, we were successful, which we thought was good, because we were trying to do something different, whereas I think the publicly funded health service was trying to do more of the same. And I think it's been very satisfying for us, and I'm interested to learn who else has done it. I heard a podcast on Radio National about something from a PHN in the south coast of New South Wales doing what they call medical yarn-ups, which was particularly to do with Indigenous people, where a group consultation, as our keynote speaker was talking about, would sit down with a group of perhaps 10 Indigenous fellows who wouldn't otherwise talk about health matters and would encourage them to have a yarn. That struck me as a really good example of doing something differently. So to be able to demonstrate that general practice can be responsible for government funds, we already had the infrastructure in terms of management and accounting and so forth, that we could deliver outcomes, I think much more efficiently and much more broadly than a publicly funded community health centre might do. We haven't had input from local government, but hopefully we can produce a model that's duplicatable in other places.
I think you all need congratulations. I think the two areas, Tim talked more generally, but the other two areas were just fantastic. I just think it's great what you've done. I'm really very impressed.
It actually boils down, Jill, to the concept of collaboration. And it's, you know, to think that you'd be competing for funds across a broad spectrum there doesn't make any sense. And collaboration is really what it's all about. And that's what commissioning through the PHN is meant to be achieving. So as it matures and unfolds, hopefully that'll be the case.